This conference will now be recorded.
Good morning, students. Can you hear me? Am I audible?
Yes, sir. Yes, sir.
Okay. So, today we'll be dealing with another surgery, that is modified radical mastectomy. So, as you know, the mastectomy means exenteration or opening the mastoid and removing all the diseased air cells. Modified radical mastectomy is a classical operation which is reserved for cholecystomy. So, previously, at the beginning of mastoid surgery, the main focus was on eradication of disease. But with passage of time, the importance of reconstructing the hearing mechanism came into existence. And then this gave rise to the concept of modified radical mastectomy. So, modified radical mastectomy or canal wall down mastectomy. So, it's a surgical procedure where the disease process is eradicated from the middle ear cleft, followed by converting the mastoid cavity, middle ear, and external auditory canal into a single, smooth, self-cleansing cavity. This is very important. So, 3S: single, smooth, and self-cleansing. So, this definition you should remember. Exteriorized through external auditory canal, leaving behind healthy tissues and future reconstruction of sound conducting mechanism whenever possible. So either you can stage the operation, that is, you remove all the disease process, do a canal wall down mastoid surgery, and don't do any reconstruction. Leave it like that, and after 6 months, you do the reconstruction work. Or where staging is not possible, you can go ahead and reconstruct it on that initial set years. So you need not stage it. Now, objectives of MRM is to achieve a safe ear. So that is the first objective, and it remains like that only. The first priority should be given to a complete removal of cholesteatoma. So cholesteatoma should be removed at any cost. Then to give a dry ear, and third is preservation and reconstruction of sound conducting mechanism. So most of the time what happens in cholesteatoma, uh, whichever ossicle is involved, that is removed. You cannot refashion, clean the ossicle, refashion it and use it, for the fear of again missing out some cholesteatoma debris on the ossicle and thereby recurrence. So but preservation means you have to preserve the stapes foot plate in the worst scenario. So stapes foot plate, even in radical mastodectomy also, is never removed, because if you remove the stapes foot plate, then the perilymph will come out and the patient will have a total hearing loss. So at least the foot plate should be preserved, or if the stapes is not involved, the superstructure of stapes, you can preserve it. So, and then in a later date, you can do the reconstruction, or at the end of the surgery, once you are confident enough that you have removed all the cholesteatoma debris, you can go and reconstruct. So absolute indication is unresectable disease, or that is where the disease is very much high, and then cholesteatoma is very extensive, and usually if the cholesteatoma mass is seen medial to the ossicular chain, then this is an absolute indication to go for a canal wall down surgery. And unreconstructible posterior canal wall. So where already the posterior canal wall is being eroded by the disease process, in that condition you have to go for a canal wall down, because the chance of retaining and reconstructing the canal wall is out of question. Failure of first stage canal wall up procedure because of poor eustachian tube function and inadequate patient follow-up. So you have done, if patient has come, there is limited cholesteatoma, you have done a canal wall up surgery, that is a cortical mastodectomy. But subsequently, in a few years down the line, this person again came to you with recurrence. So now this is the opportunity to do the canal wall down surgery. So because what happens, there are few hidden areas in the middle ear, mainly the facial recess and the sinus tympani. So these things, disease clearance from facial recess and sinus tympani should be done. Otherwise, the chance of recurrence rate is high. And another hidden area is the mastoid tip, because some surgeon who do a inside out technique, they just follow till the fundus of the cholesteatoma and they don't open the mastoid tip, or the sinudural angle. There, if the cholesteatoma extends into the sinudural angle, then it's a difficult area, and some surgeon might miss it. So in this condition you will have a recurrence, and then it is better to do a second, if the patient is willing for surgery again, so this time you go for a canal wall down surgery. But now what happened with the advent of endoscope, that is even the angled endoscope for ear surgery, the canal wall up is being preferred by those who do endoscopic ear surgeries. So they try to preserve the canal wall, because with it is it is relatively easy to see the sinus tympani area with the help of endoscope, and that is an angled endoscope rather than a microscope. So but for that again you have to be trained, and you should be good enough to visualize those areas and identify the pathology. Then inadequate patient follow-up, the best is canal wall down, because if you do a canal wall up surgery and patient doesn't come for regular follow-up, or he or she is staying in a place where communication is poor, then it is always better to go for a canal wall down. Relative indication, disease in an only hearing ear or in a dead ear. Medical illness like uncontrollable hypertension and diabetes, because these patients cannot be operated multiple number of times. So you have to do a full and final job here. Once, because this hypertension and diabetes, if at all it is very much required for you to do the surgery, then with a lot of difficulty you have to convince the anesthesiologist to give anesthesia, because these canal wall down or MRI minimum takes 3 to 4 hours. So giving a anesthesia for 3 to 4 hours in hypertensive and diabetic patient is also very is risky. So that is the thing. So if the anesthetist agrees, then you should do a full and final job. Severe otologic or central nervous system complications and neoplasms, obviously malignancy warrants a canal wall down surgery, and poor eustachian tube functions also you go for a canal wall down. So contraindications, obviously present of otitis media with the coalescent mastoiditis, persistent secretory otitis media, chronic allergic otitis media, tubercular otitis media. And relative contraindication include wide exposure of sigmoid sinus, dura, and facial nerve caused by aggressive disease. So in these cases, it is better not to go for a canal wall down, because if you do a canal wall down, then what happens? The sinus, sigmoid sinus may prolapse into the external auditory canal, or even the brain may herniate into the external auditory canal. So you have to, in this condition, you have to have a posterior bony meatal wall. So modified radical, have I taught this in the last class? Hello, can you hear me? Hello, can you hear me?
Yes, sir.
Acha, till have I taught this in the last class? Huh? As far as I remember, I think last week I didn't take your class, but the week before that I took. I think I have partially covered this lesson, modified radical mastodectomy. Okay, anyway, unnecessary. We'll again repeat it. What is there? So, modified radical mastodectomy is also known as complete mastodectomy and tympanoplasty. It is an evolutionary surgical development that attempts to incorporate the major goal of cholesteatoma surgery, that is exteriorization of disease with sealing of middle ear space to avoid chronic drainage from exposed mucous membrane. A primary feature of modified radical procedure is complete removal of posterior canal wall, the major reason for failure of the Bondi procedure. Now, the Bondi operation, which is also a part of canal wall down surgery, is an inside-out technique. That is, you start from the attic and you follow the cholesteatoma sac into the from attic, you go to aditus ad antrum and then antrum till where you see the fundus of the sac. So where you see the fundus of the sac, there you stop the operation, and thereby what happens, the advantage is the cavity is very small, but the disadvantage in body operation is the posterior canal wall is not brought down to the level of facial nerve. It is very high, and very rarely a surgeon goes up to the level of the mastoid tip. So this what happened ki, there was a lot of recurrences after Bondi's procedure. So that is why this procedure surgery went into disrepute. Now hardly people do a Bondi operation. So the Bondi procedure was predicated on philosophy of limited dissection of canal wall and mastoid region. And this technique, although often sparing hearing in the short term, resulted in recurrent cholesteatoma or at least persistent oral discharge because of subsequent infection of remaining mastoid acids. So that is what. So although it spares, and in the Bondi procedure, no, another thing is you don't enter into the pars tensa area. You are only concerned with the pars flaccida and above. So in this surgery, no, you don't elevate the even the tympanic annulus. So that much sure that the middle ear, particularly the mesotympanum, is totally free of disease. Then only you do this surgery. The radical mastectomy, although effective dealing with more extensive bone dissection, results in chronic oral drainage because of the removal of all the remaining mucosa in the exposed middle ear. Now, radical mastectomy, the difference between modified radical and radical is both are canal wall down. That is, there is no argument. But in radical mastectomy, the remnant tympanic membrane is removed, and number two, there is no hearing reconstruction is done, and the eustachian tube is permanently closed off. Three things are done. So no effort is being given to reconstruct the hearing. Whatever remnant tympanic membrane and remaining mucosa of the middle ear are all removed, and the eustachian tube is permanently closed. So with these three things are not done in modified radical, where you try to reconstruct the hearing, and you retain the good mucosa, the mucosa which are healthy, and you never close the eustachian tube orifice. So the modification of radical procedure, that is by adding the technique of tympanoplasty, potentially eliminates the expected intermittent discharge from middle ear mucosa. So here what you do, you graft the drum either in the single setting or as a separately, but you graft it. So thereby the recurrent discharge, chronic ear discharge, which was a typical problem encountered in radical mastectomy, is not seen in modified radical. So there are two approaches I think we have discussed, endoral and postoral. We usually go with the postoral approach, and the advantages of a postoral approach is residual cholesteatoma is visible on follow-up, recurrent cholesteatoma is rare, and there is complete exteriorization of facial recess, and second stage is rarely required. If done properly, is very rarely required. Disadvantages are mastoid cavity problem. This cavity problem um, is created by the surgeon only. So if you don't have that acumen of how to reduce the size of the cavity, then the patient will have the mastoid cavity problem. So majority of cases, no, it is the surgeon at fault, not the patient. Although patient factors are there, but maybe say 20-30% patient, but 70 to 80% it's surgeon fault. The most common fault which causes a mastoid cavity problem is keeping a high facial recess, high facial ridge. So when you are doing in this surgery in your early days, no, you treat facial nerve. You are very much afraid of facial nerve, and thereby you don't drill the facial ridge down enough to have a down enough to avoid the mastoid cavity issue. So the high facial ridge is one of the most common cause of mastoid cavity problem. And number two is not doing an adequate myotoplasty. So myotoplasty is nothing but, you see, this is the opening of external auditory canal, because this opening is sufficient to ventilate the external auditory canal. But now you have to ventilate the mastoid also. So you have to enlarge the opening. So only enlarging the opening is known as myotoplasty. And once you enlarge the opening, no, then more amount of air enters, and that helps in epithelialization of the mastoid. So the earlier the mastoid gets epithelialized, uh, earlier the problem of discharge and everything will subside. Position of pinna may be altered. Obviously, some amount of alteration will be there. Post-operative vertigo due to caloric stimulation of lateral semester. This is a very important shortcoming of a modified radical or radical mastectomy, because you have brought down the canal wall. So now the lateral semicircular canal is completely exposed to the outside. So previously the lateral semicircular canal was closed from the outside, but now it is exposed. So once, suppose you are taking bath, you by mistake you took a head bath, and then water enters, or even the cold air also can stimulate a caloric response. So that is characterized by vertigo and nausea, vomitings. So that happens. So what we do, we advise to this patient that when you are going in a bus or you are driving a vehicle, it is always better to put on a helmet, or at least to cover it with a cotton plug, so that the air doesn't directly go and hit into the uh, lateral semicircular canal. So pre-operative assessment, the decision to perform a MRM depends on the extent and location of disease. So for MRM, suppose for a surgeon to decide that this case he or she will do an MRM, depends on one thing, is presence of cholesteatoma. So once you establish that this patient has a cholesteatoma, then and from there you start thinking about MRM first. Then any previous surgery, suppose you are working in a apex hospital, so obviously you will also see patient who has or had undergone ear surgery few years back, and now there is a recurrence. So how to suspect that it's a cholesteatoma? The typical purulent, scanty, foul-smelling discharge will tell the diagnosis then and there. So previous surgery history is there. Then you have to, if you have the records of the previous surgery for what the patient underwent the operation, it is very, very good. But if you don't have the records, then at least you can examine the patient, and you can ask few leading questions about the discharge at that time, when he decided to get it operated. So how was the discharge, whether it was foul smelling? So by asking these questions, you can have a rough idea. Eustachian tube function. So already we have discussed a patient with poor eustachian tube function. Usually MRM is preferred. Patient's age, medical condition, and aftercare preferred. preference. Careful microscopic inspection and cleaning of the ear aid in the decision. Now, this what happens in case of a etiquantral disease, the discharge is very scanty now. So few people they even don't know that they are having this. But on clean, they say that when I clean the ear, then I find little bit of pus is there and it is foul smelling, or there is some bleeding. So that brings the patient to you. And then when you see in these cases, sometimes you find little wax in the attic. So presence of wax in the attic should alert the ENT surgeon that that is not normal. Normally, you don't see wax in the attic. So what happens because the discharge occurs so slowly and it dries up on the surface, and slowly a crust-like thing appears, and over that the dust and all debris they form and then lead to formation of wax. So once wax is there, you have to take the wax out in order to have a good view. So sometimes after removal of wax, you can see the presence of a defect in the attic and presence of frank cholesteatoma. Pus, mucus, and cholesteatomatous debris should be removed under microscopic suction. So you can do it, but some patients tolerate well. Some patients have intense vertigo. So when you are doing a suction cleaning, you should ask the patient about vertigo. So some patient also may have a vasovagal attack also. So you tell your assistant to put a hand on the pulse and check for the pulse rate. And when you are doing any maneuver over the attic region, whether the pulse rate is going down or not, just to inform. Because why the heart rate excuse me. Why the heart rate decreases is because of the auricular branch of vagus. The auricular branch of vagus supplies the posterior wall of the external auditory canal. So when you are manipulating and then vagus is getting stimulated and vagus supplies to the SA node, thereby even the heart rate decreases. So patient will have bradycardia, cardiac output decreases, and then there is in pooling of the blood in the periphery, leading to a vasovagal attack. So polyps can be removed with gentle traction. Sometimes you may also see a polyp or granulation tissue, and significant retraction should not be given to the polyp since it may be attached to facial nerve or matrix of cholesteatoma or matrix of a labyrinthine fistula or even stapes superstructure or foot plate. So always it's very dangerous to pull the polyp. So not required actually. If you are seeing a polyp and then it's always better to leave it as like that. Don't try to pull it out. Rather you can just, if you want to take a biopsy, you just take the suction tip or you take a scissors, micro scissors, and just cut it and send it for biopsy. Don't pull it. So excessive destruction of posterior canal wall with obvious cholesteatoma invading the mastoid indicates the need for MRI. So these all how to know because radiological investigations, particularly X-ray is good enough, but some cases, particularly if it's a revision case, already operated case, then it is better to go for a high resolution CT scan of temporal bone. So X-ray of the mastoid showing a large mastoid cavity indicates a big cholesteatoma. So in that case, you mentally prepare yourself to do a canal wall down surgery. So active suppuration or infection should be controlled prior to surgery. So here we admit the patient and immediately we take a oral swab and send it for culture and sensitivity, and we start the patient on a antibiotic which has a good gram negative coverage. So and good gram negative and also which also has a good activity against pseudomonas. So a good antibiotic which is cheap and has a good anti-pseudomonal activity is the fluoroquinolones. So ciprofloxacin, levofloxacin, ofloxacin, they are very good. They have very good activity against fluoroquinolones and also gram-negative organisms. And you can also include anaerobic, because the flora is not limited to gram-negative. It may be multiple, it may be gram-positive, gram-negative. It's a mixed flora. Acetic acid irrigation followed by antibiotic drop should be instituted for several weeks prior to surgery. So this acetic acid is a keratolytic agent. So 2% acetic acid you just instill, and then that removes the debris, that removes the keratin debris, and thereby allowing the antibiotic drop to penetrate. So after so the acetic acid solution is made by mixing 1 part of white vinegar with 2 parts of boiling water, and after cooling the solution is instilled into ear several times using an infant nasal bulb syringe to mechanically debride the area. Antibiotic ear drops are instilled after irrigation 2 to 4 times a day. So preparation, obviously, I hope few of you might have seen how the patient is prepared. Anyone who has seen how the patient is prepared before surgery? Hello? Am I audible?
Yes, sir.
What is your name? Hello? Am I audible? I think you should respond from that end. Otherwise, it's very difficult to know.
Yes, sir.
119 students. You have seen? Have you seen the patient being prepared before surgery?
No, sir.
No. Who has seen any one of you of the 119 students who have logged in? Any one of you have seen? No. No one? Acha. So, so the hair, this preparation is done 1 day before the surgery. The hair is shaved at least 2 finger width above the pinna and also behind the pinna, and is clean. The skin is cleaned, and this is done 1 day before the surgery, and then you have to give some anxiolytics to the patient, and antibiotics are started the day before the surgery. But if the report comes of culture and sensitivity, so then we stick to the antibiotic which is the most sensitive, and then you give some anxiolytics. Usually we give here alprazolam, 1.25 milligram in the evening, and the day before surgery, and 6 o'clock in the morning. And then we also do a xylocan test dose, if at all the patient, whether the patient is sensitive to xylocan or not. So then the patient is shifted to the OT the next day morning, and the skin is cleaned and sterile drape is applied. A mattress is taped securely to the operating table to prevent slipping when the table is tipped from side to side or into Trendelenburg position. Patient is placed with his or her head at the end of the table. So this all patient positioning is done. And surgery can be performed both under LA as well as GA, but in children and for surgeries which require long duration, GA is preferred. So local anesthesia, you should give adequate infiltration in the post-auricular area with 2% xylocan and adrenaline. If there is no hypertension, then you can go ahead with the xylocan and adrenaline 5 to 10 minutes before incision is made. So how much to give is the that is, if you are giving adrenaline, it is 7 milligram per kg body weight, and if you are giving plain xylocaine, it is 5 milligram per kg body weight. So adrenaline, is a vasoconstrictor. So what it does, it increases the duration of effect of xylocaine, number one. Number two, it also prevents development of complication of xylocaine toxicity by not allowing it to be absorbed very fast into the circulation. And third, it reduces bleeding because it is a vasoconstrictor by itself. So 4-quadrant infiltration is given in at the bony cartilaginous junction on the posterior, superior, inferior, and anterior canal wall. So this is done. So this is the incision, which is the William Wild's incision. Here you infiltrate here, here, and here, mastoid tip area. You infiltrate here, and you make sure that you infiltrate here, that elevate the tympanomeatal flap. So do a little bit of hydrodissection by infiltrating here, and then you infiltrate in the canal. So wait for 5-10 minutes, give the Wild's incision, and after giving the Wild incision, you deepen it till you reach the periosteum. And then once you reach the periosteum, this T-shaped incision is given on the periosteum. Before that, you can harvest a graft of temporalis fascia. Some surgeons prefer to harvest it at the end, but if you harvest it in the beginning, then by the time you finish the surgery, the graft will be dry enough, and a dry graft is easy to handle than a wet graft. So this T-shaped incision, a horizontal incision, passing just below the insertion of temporalis muscle, starting from the root of the zygoma, and this incision up to the mastoid tip. So this incision is given up to bone deep, and then the periosteum is elevated anteriorly and posteriorly. So, and this flap is elevated superiorly. So 3 directions they are elevated. So this incision is elevated superiorly. From here you elevate anteriorly. From here you elevate posteriorly. So thereby exposing the bone, and after elevating you apply the retractor. So this retractor is applied when you are harvesting the graft, and also after giving the incision you can elevate the retractor. Sorry, you can put the retractor. Sorry. And then it becomes roughly like this. So the what you say, this is the anterior end, this is the posterior end. And then once you elevate anteriorly, you will come across the spine of Henle, which is a very important surgical landmark. Important surgical landmark for mastoid antrum. So the mastoid antrum lies just posterior superior to the spine of Henle, roughly half-inch medial to the cortical mastoid bone. So you have to drill for at least 1.3 centimeter to come across the mastoid antrum. Okay. So always start with a burr. Either you can use a conical burr or a round cutting burr, and always choose the highest possible size of the burr, cutting burr, and highest possible size of the cutting burr. And then you start marking out the area. So there are you should form a triangle here. That is on the triangle of attack. So before so once you see the spine of Henle, then what you do is you elevate the tympanomeatal flap. You elevate the tympanomeatal flap. After elevating the tympanomeatal flap, you just medial to the spine of Henle, you give a horizontal meatotomy. The procedure is same. A horizontal meatotomy is given, and then this uh, a gauge is passed through the external auditory canal, taken out through the meatotomy, and the pinna is pulled anteriorly. Once the pinna is pulled anteriorly, then you apply the mastoid mollisson self-retaining mastoid retractor. So then what happens? This flap totally lies anterior to the retractor and doesn't come back, does not come back into the field of surgery. Similarly, this flap is also elevated and taken posterior to the mastoid retractor. So this also doesn't come. Another retractor you can apply right angle to this here and here. So this retractor is applied. The prongs are lie just below this line, so that this flap is taken up and here up to the mastoid tip. So there are two retractors at right angle to one another. So now totally the mastoid area is free for you, and then you have the what you say the spine of Henle as a guide, as a important landmark, and then you start the drilling. So in drilling you make the three cuts. The first cut is along parallel to the curvature of external auditory canal, coming right up to here. The second cut is a line drawn parallel to the temporal line, going as far posteriorly as possible. And the third line is a tangent joining the first line and the second line. So you join it. So now it forms a triangle, and this is called as the triangle of attack. So you have to stay within this line. So then you are safe. And ideally, after making the triangle of attack, you start the drilling posterior superior to the spine of Henle. Okay. Then you go on drilling medially and try to identify the antrum. So the antrum is identified by seeing one picture, that is, once you see the dome of lateral semicircular canal, then you say it is the mastoid antrum. So until and unless you don't see the dome of lateral canal, you cannot say with 100% that this is the mastoid antrum. So now you are dealing with cholesteatoma. So once you see the sac, you are when you approach the antrum, the sac comes into the picture. So what you can do is you can just give a small incision in the sac and suck out the keratin debris, and then either you can remove the sac piecemeal, or you can drill around the sac and try to remove it as a whole, but that is not always possible. So you can remove it piecemeal, but if there is cholesteatoma sac over the lateral semicircular canal, then you should be very careful um, before teasing it out, because sometimes what happens is the cholesteatoma, after um, eroding the bone, sits over the semicircular canal. So in this patient, no, if you do fistula test also before operation, it will come as negative. So this is a bright example of a false negative fistula test. So even though fistula is there, but still you are getting negative. So it is called as a false negative. So another cause of false negative fistula test is where the labyrinth is dead already. So if the labyrinth is dead, then you cannot elicit the fistula test, even though fistula is there. So once if you see that cholesteatoma sac is lying over the horizontal semicircular canal, gently palpate the canal for any gently palpate the canal. If you find that there is at some point there is a giving away sensation, then you for time being you keep the cholesteatoma there, and remaining areas you concentrate. remaining areas you concentrate. So that is why what happens key in all cases of cholesteatoma, we advise a CT, high resolution CT scan. So this high resolution CT scan will recognize this fistula before this surgery. So that is why if you know already that fistula is there, then you are mentally prepared rather than knowing it on the table. Now, then opening of the antrum is enlarged by removing of cells superiorly and posteriorly. So superiorly, these are cells that is known as the retrolabyrinthine and supralabyrinthine cells. So you try to remove it and follow the cholesteatoma to where to all the cells where it goes, and try to remove the cholesteatoma sac. Okay. So first you have to do a simple mastectomy and then convert it into a modified radical mastectomy. So like that simple mastectomy we have discussed already, and so here you can see a simple cortical mastectomy done. Okay, can you see? This is the dome of lateral canal. Okay, and this area is the tip here. Okay, and this is the posterior canal, and this is the lateral canal. Superior canal is very deep, so sometimes it's not required also to open. This is the sinodural angle. So this is the tegmen plate. Okay, and this is the this is the sigmoid sinus plate, and this is the dural plate. Okay, this is the sinodural. See how it is opened up nicely, and these are the tip areas which has been totally opened up, and the posterior meatal wall is preserved. Okay, here you will find the adductus ad antrum, and near that on the floor of adductus ad antrum you will find the in short process of incus. So the short process of incus should be preserved if it is not involved by the disease process. So because now the importance is now equal weightage is given to the reconstruction of hearing mechanism. That's why you should not miss out on any opportunity to reconstruct the hearing. So you can see here very nicely, and this is the attic area here, and this is the spine of Henle that has been preserved till the end. Okay, so and this is the you can see this is the middle ear, and this is the promontory, and this is the bony external auditory canal. Okay, so now this once you see this picture, that means you have come to the end of simple mastectomy. Okay, so the additional thing what is done here is this part, from here. Can you see? So this is the attic region here. So from here, all this bone till here is removed in case of modified radical mastectomy. So you remove all the bone in case of modified radical mastectomy, and the whole attic area is exposed to outside, and this by removing this, the mastoid is also exposed to the external auditory canal. So atticotomy or epitympanotomy is done by removing a triangular area of bone bounded superiorly by suprameatal crest, inferiorly by line along the posterior superior canal wall, with apex pointing towards zygoma. So this is the atticotomy. Okay, this is the zygoma. The apex points towards the zygoma. The depth at which outer attic wall is reached is just lateral to notch of ravinus. The bone removal is carried out anteriorly to expose the short process of incus. Further anteriorly, the incudomalleolar joint and the head of malleus are seen. The dissection stops at the anterior wall of epitympano. So The malleus head and incus are removed if cholesteatoma matrix envelops them or goes medial to them. So I was telling in the beginning of the lecture that any cholesteatoma mass lying medial to the ossicular chain warrants a modified radical mastectomy. So it is difficult to clear the cholesteatoma debris the ossicular because the first preference is the disease control. Someone please switch off your mic. Someone who has kept your mic on, please mute your mic. Hello. The sound which is coming on the whole class. At least have that decency enough to switch off your mic. Till the mic is on, I'm getting the sound of background sounds are coming. So so in order to get a good disease control in the attic you have to remove the malleus head. And once you remove the head of the malleus, then what happens is you can remove the disease process from the attic very nicely. And also you can go into the anterior attic area. So as you know, the attic area is divided into a small anterior attic and a large posterior attic through a small bone which projects from the tegmen, that is known as the cog. The cog lies just anterior to the head of the malleus. Once you remove the head of the malleus, the next thing that lies in front of you is the cog. So you drill out the cog to enter into the anterior epitymplanum. That also cholesteatoma mass has to be removed from the anterior epitymplanum. If you leave it, then definitely the patient will have a recurrence. So here you can see this is the cholesteatoma sac being removed from the attic region and the atticotomy being done with a cutting burr. So with the cutting burr, the size is whatever surgeon is free or convenient to use, that size is used. So the sac is opened cautiously in case dura is mistaken for the sac. Cholesteatoma contents are removed by suction and instrumentation, and the sac furthest extension anteriorly, superiorly, and posteriorly are explored with a blunt mastoid surgeon. So, so they're very, very important actually. Whether it's a sac or it is the dura, you have to establish. So, a dura will typically have a pinkish hue, and when you press, no, if it is a sac, then you will feel a bone stop. That is, when you press onto the sac, superiorly you will get a bony resistance. But if it is the dura, no, then the tegmen bone is already eroded. So there won't be any bony. You will get a soft feeling. So if you are getting a soft feeling, that means it is the dura. No need to incise. If you incise, it will bleed profusely. If you are getting a hard feeling on pressing the sac, then definitely it is a cholesteatoma sac. So the entire matrix is removed with following exceptions. One, where in certain conditions, even though the matrix is there, you should not remove. One is the matrix is firmly adherent to exposed dura or sigmoid sinus. That may be left rather than risk injury to these structures. So you can leave the matrix and don't try to pull it off. And then matrix over a fistula of semicircular canal may be left to avoid post-operative labyrinthitis. And some surgeons prefer to dissect the matrix from the fistula and immediately apply a thin fascia graft. So that is why if you are finding that there is a fistula in the lateral canal, that has to be addressed at the end of the surgery, where you have removed all, you have cleaned the disease process everywhere, and at the end you just remove the matrix and put the facial graft. Matrix firmly attached to exposed facial nerve, you can leave it. Matrix extending into the mesotympanum and covering the stapes footplate may be left in at the initial operation rather than opening the vestibule, with the risk of again serous or suppurative labyrinthitis. So at a second operation, after the ear is dry and healed, cholesteatoma matrix can be dissected from the oval window and tympanoplasty can be done. So these are some special situations where knowingly you leave out the cholesteatoma. So if you are allowing few matrix to remain, then it is advisable not to graft it. So after 6 months, you see, and if you find that the matrix and all have epithelialized very nicely, then you can go and graft it. The results will be very good. But if you leave behind the matrix and then graft it, then immediately the cholesteatoma might recur. So next class we will continue from here. Okay. Just hold on. I'll take your attendance. Okay, thank you.